Is that
Yes.
thank you?
Yes.
Yes.
It's a pleasure to be in a group. And as I said earlier, it's my first TED talk with the pun intended. So it's a great pleasure to be amongst the oculoplasty people, the lone ocular motility person being
Mhm.
here. So, and my talk comes in the order in which the strabismus surgeon is called in for
Definitely.
thyroid eye diseases. So I think it's quite in order that we know that by now all these things have been talked over. What's the cause of thyroid eye disease? The epidemiology, which is hitting more of the older people and more females, predilection being there, and it can occur in hypo, hyper, as or the euthyroid states. We know that the pathophysiology has been talked about, and there are good medical treatments which are on the horizon, which will probably make the life of the thyroid eye disease individuals much better in future. Of course, they are very costly at the moment and not available in our country. We all know that the major problem is with the extraocular muscles, and uh, these are the reasons why they may be causing proptosis as well as this thyroid optic neuropathy or even strabismus by itself. This is an individual who had come to us. He has a bilateral restrictive strabismus. There is a limited elevation and a marked esotropia, and the interesting part was that the esotropia is worsening in up gaze, probably because of a co-contraction, just like what you have in Duane's retraction syndrome. The superior rectus is working against a tight inferior rectus, which causes a increase of the esotropia, which is happening. So these are the details of the ocular motility of this individual who was also a gardener by profession. And so his field restrictions were very important for him. We saw that there was about a 35 prisms base out ESO, and which became more in the up gaze. And on doing the force reduction test, we had, could see that there was a tight force reduction test both for the inferior recti in both the eyes and for the left medial rectus in the left eye. So in such a situation, we went about doing the inferior rectus recession. Uh, but since we are doing bilateral inferior rectus recession, which are supposed to be adductors, we need to compensate for the loss of the adduction, which may happen and cause a worsening of the A pattern, as was already there in this. And we did a nasal transposition, and the minimal amount of IR recession required as per the FDT, which happened to be 4.5 millimeters in this case, was done. The medial rectus recession was also about 5.5 in this case, and we had also upshifted the medial rectus again for the A pattern ESO, which was there. And these are the post-op pictures of this individual who has now the ESO corrected, and the up gaze is improved because of the inferior rectus recession on either side, and the A pattern has also been taken care of. How do we do, what are we going to deal, and what's the ideal approach was the topic given to me. There is nothing which we can say as ideal, but I would say what is optimal that we can do in these cases of thyroid eye diseases. There is a very nice article which has come in JPOS in this year, and that is probably also the largest and the latest that is coming in the surgical treatment of strabismus in thyroid eye diseases. Let's have the salient features of this. This article is from Bascom Palmer Institute, Miami, Florida. They have a retrospective study on 76 patients in which 87 surgeries were done, 43 on the vertical muscles, 16 on the horizontal, and 28 done concurrently. 50 of these 76 patients, that means 66% were females. The mean age happened to be 62.2 years. The median duration of strabismus was 13.5 months, so which also confirms the fact that mostly the strabismus treatment is little late once the eye and the thyroid eye condition are both stable. 61% of these had a prior orbital decompression done, but we cannot really only blame orbital decompression for the strabismus, because 9 had strabismus only after decompression. The rest had even prior to the decompression being done. 66 of the 87 were tackled by an adjustable strabismus surgery, which is a very interesting thing that we should always note. 42 of the 87 cases had inferior rectus recession done, and 11 of the 87 had the superior rectus recession done. The next common muscle to be tackled was medial rectus, which was 20 in bilateral and 13 in the unilateral cases. What was the motor success in these cases? If we go by the criteria of a prism diopter in primary position, considering as less than 5 in for vertical and less than 10 prisms of horizontal deviation, 60 of the 87 cases, that means about 69%, had a motor success. Concurrent was as good as sequential, but there were 27 failures. Now, if we analyze these 27 failures, we can see that 16, that means about 59% were undercorrected and 41% were overcorrected. So there is no simple way of just changing your nomograms. You would have to resort to an adjustable surgery. And as is also seen that in second surgery done, it improved the statistics to 76% from 69%. The sensory success by taking the absence of diplopia in the primary position was achieved in 58%. And again, the concurrent was better than the horizontal, but poorer than the vertical alone. It was improved again by second surgery from 58 to 59% only. So what is the role of adjustable surgery? As I said, it was 66 cases were done. It was seen that 67% were of the age group being females and 61.2 were the age group. And these are both matched in the non-adjustable and adjustable ones. The motor success in the adjustable was 76%. So it is as good or little better than the repeat surgeries done when they were non-adjustable, compared to 48% being the success for motor success in non-adjustable group. The sensory success again was 61% in the adjustable group versus the non-adjustable being just 47%. So it's definitely a role of doing an adjustable surgery. Way back in 2003, I happened to be in Wales for my fellowship, and we had done a paper with Dr. Robert Renicky, who is talking about single stage adjustable strabismus surgery. In this article, we had 7 cases in which this thyroid eye disease was being tackled, and the inferior rectus was done. And it is seen that there is a possibility of progression of the overaction of the inferior rectus. That means the slippage of the inferior rectus is one problem which we have to be taking care of. So when we do the adjustable surgery, the differences in our surgical approach would be, we mark it the same way, but we will pass the needles, leaving a space for our adjustment. I usually prefer to do a hemi hangback and not a full hangback, which prevents the collapsing of the muscle, and we can have a more proper placement of the muscle. And also remember that in this case, for medial rectus, a vicryl suture has been used, 6-0 vicryl, but for the inferior rectus, the recommended suture would be a 5-0 ethibond, which is a non-absorbable suture, as we talked about that there will be a progressive overaction or recession in cases of inferior rectus. The adjustable strabismus surgery can be done by 2 different techniques. You can do either by the slip noose technique, or you can have a 1.5 knot, which can be released and corrected. So in the COVID times, I think we are very familiar with these masks. Just to remind you that the sliding noose is like one kind of mask, which is on the left-hand side, and the 1.5 knot is the other kind of mask that we are using. Both can be used as per your choice. Intraoperatively, we can adjust as per the force reduction test. And as Dr. Renicky had mentioned, a single stage adjustable surgery under topical anesthesia or IV conscious anesthesia using midazolam and fentanyl. But most commonly, we are using the double stage adjustment, that is after 5 to 6 hours of the first surgery, that the adjustment can be made. Dr. Rosenbaum used to do after 24 hours. This is Dr. Rosenbaum, who is no more with us. And so the adjustment can be done after 5 to 6 hours. And as I said earlier, that almost half of the cases would be requiring adjustment, and we don't know whether to over or under do, but only do it on the actual adjustment basis, that we can ensure a diplopia-free position to the patient. So to conclude my talk, I would like to say that we need to look for stability. First of all, the systemic stability and also the ocular stability before we venture into a strabismus surgery. Secondly, we look for the involved muscles. And third, look for the force reduction test preoperatively, intraoperatively, and also at the end of the surgery, we should ensure that the FDT is free. The plan could be concurrent or it may be sequential, preferably a concurrent one, because both the horizontal and vertical muscles would be involved, and it is better to give a diplopia-free position to the patient using on both horizontal and vertical muscles. Adjustable is preferred, and for the inferior rectus, I would say that we should use a 5-0 ethibond suture to prevent the progressive overaction. This probably is also because the superior rectus may be tight and the inferior rectus, which has been recessed, can fall back, working against a tight superior rectus. Also because of the Bell's phenomenon, which consistently rolls the eyeball up, and the inferior rectus is always likely to be recessed more and more. So a non-adjustable suture would be preferred for the inferior rectus. And a nasal shifting of the inferior rectus should also be done in cases when we are doing bilateral IR, as there would be a pattern exo if we do not do this. So these are the take-home points which I would like you to go with this. Thank you very much for giving me this opportunity. Thank you all.